A very good morning to all of you. Once again, welcome to the teaching class of Department of Urology, Savai Mansingh Medical College, Jaipur. Today, we have a class on CA penis, carcinoma penis, and it will be presented by our resident, Dr. Sarvesh, and the moderator is our faculty, Dr. Dharmendra. So I would request Sarvesh, please go ahead with your presentation.
दूसरा लैपटॉप होगा कनेक्शन इसे अनस्टेबल आ रहा है कनेक्शन नहीं आ रहा है
Go ahead.
हमने स्टार्ट कर दिया वो लैपटॉप हो गया
Full screen, please.
Good morning, sir. Colleagues.
Go back to your first slide. Go back to your first slide.
Sir, my name is.
Go back to your first slide.
सर ये फर्स्ट स्लाइड ही है सर
ये नहीं यहाँ पर शेयरिंग में जो आ रहा है वो नहीं हो रहा है What we can see is your fifth slide. आपने जो लगा रखा है पावर पॉइंट पे उसको पहले फर्स्ट पे जाके और फिर ओपन कीजिए Go back to your first slide, please. Yes, full screen. Full screen.
So internet connection थोड़ा सा प्रॉब्लम कर रहा है
Yes, go ahead.
Good morning, sir. Sir, my name is Dr. Sarvesh, and my seminar topic is CA penis. Cancer of the penis are uncommon tumor that are often devastating for the patient and frequently diagnostically and therapeutically challenging for the urologist. Although rare in non malignant neoplasms considered subsidiaries, penile carcinoma accounts for the 0.4 to 0.6% of all malignant neoplasms among the men in United States and Europe. It may and Europe. It may represent up to 10% of malignant neoplasms. Video stop video. सारी सेटिंग बंद कर देते हैं एक बार। इतनी बार
आपने डेस्कटॉप पे सेव किया था
यही है।
इसको कर लो, इसको कर लो, शेयर करो।
एक से क्या है यार।
शेयर
चलने देते हैं। It may represent up to the 10% of malignant neoplasm in men. In African, in Asia, African and South American countries. Bile cancer is a disease of older men with an abrupt increase in incidence of 6 decades of life. The tumor is not unusual in younger males. 22% of patients are younger than 40 years and 7% are. The disease has also been reported in children. Aortic pelatitis, condyloma acuminator, cubitis patch on prepuce or glands, often involving the meatus, glandular erosion, feces may injectable steroid. Surgical stenosis is a common problem. Vascular Levenstein tumor, varicose carcinoma. True incidence is unknown. Invades locally, compress the adjacent tissue. carcinoma, pain is 5%. Penis called as esophageal correct. If it is involved the class penis and vision penis and prepuce, or Bowen's disease if it is involved the penile shaft or other reminder of the genitalia and perineal regions. Both are and scaly erythematous treatment is in preputial region, circumcision or excision with 5 millimeters margin. In glandular region, topical 5-fluorouracil cream. Five liquid cream or ACS. Primary tumor, both glans and prepuce approximate 9%, and in coronal region 6% and soft less than %. Etiology: lack of neonatal circumcision, poor hygiene, phimosophy, penile trauma, neonatal circumcision, poor hygiene, phimosis, have spread to the regional and iliac nodes. Flat and ulcerative lesion more than 5% and extended more than 75% of the shaft have higher incidence of metastasis or survival. Buck's fascia acts as a temporary natural barrier to the local extension, protecting the corporeal bodies from the invasion. Penetration of Buck's fascia and the tunica albuginea permits the invasion of vascular weakness, weight loss are secondary to chronic suppuration. On the node, both may occur. Symptoms refer to metastasis are the rare. Signs: the presentation range from the relatively subtle it as a simple or area may be due to vascular invasion and the histological grade of the lesion. Radiological studies: chest X-ray, mainly for lung metastasis. Penile ultrasonography. Sensitivity is of sensitivity of inguinal region in obese Newer properties. Nanoparticle ferrum oxytran 10 particles are and PET scan of the inguinal region have shown promising result in the detecting of minimal inguinal metastasis. Lymph node. NX cannot be assessed and not lymph node, and one is palpable mobile unilateral inguinal lymph node, and two is palpable mobile multiple or bilateral inguinal. Distance metastasis treatment of penilis.
आ रहा है?
आपके आगे वीडियो से इसमें इस लगी थी वापस आवाज आ रही है रिज्यूम शेयर जल्दी यहाँ पे फुल स्क्रीन
Local recurrence rate is 8 to 30%, were highly associated with the tumor size 3 centimeter, advanced stage, and failure of previous definitive therapy. Most micrographic surgery best suited for the patient with carcinoma in situ and small superficially invasive tumor with cure rates comparable to the partial penectomy. Complications include metal stenosis and glass disfigurement. Laser ablation. Circumcision is generally recommended at the time of laser therapy if it is not already have been done. The four most widely used laser energy sources are CO2 laser, Nd:YAG laser, and KTP lasers. CO2 laser skin depth is 0.01 mm. CO2 laser represents optimal therapy for carcinoma in situ. However, local recurrence rate up to the 33%. Nd:YAG laser, most commonly used laser, depth of penetration is 3 to 6 mm for treating small superficial penile lesions. Local recurrence rate has been approximately 20%. KTP lasers, intermediate depth of penetration, better hemostasis than the CO2 lasers. Disadvantage of laser therapy: tissue for tumor grading and assessment of margin is not provided. Difficulty in determining the exact depth of laser coagulation. Inability to treat larger lesions, and potentially difficult healing in patient who has obese, immunocompromised, or receiving anticoagulant therapy. Penile amputation. Penile amputation remains the standard therapy for the patient with deeply invasive and high-grade tumors. Partial or total penectomy should be considered in patient with tumor of size 4 centimeter or more, grade 3 lesions, and those invading deeply into the glans, urethra, or corpora cavernosa. Partial penectomy. Partial penectomy remains the most common surgical procedure for the treatment of the primary tumors in the patient with invasive squamous cell carcinoma. Successful local control is accomplished in the majority of patients by imputation of the penis at least 2 centimeters proximal to the tumor. Additional goal of procedure are to preserve the ability to wide in a standing position or possibly to allow the sexual function. Local recurrence rate after partial or total penectomy ranges from the 0 to 8%. The complication is urethral metal stenosis, inability to wide in upright position, spraying of the urinary stream, inadequate sexual function. Procedure: incision with ligation and division of dorsal penile vessels within buccal fascia, and B is corpora transected and urethra spatulated. C and D represent the closure of corpora cavernosum and final closure with construction of ureterostomy. Total penectomy. Total penectomy, it is a bit of misnomer because the penis is amputated at or near the level of suspensory ligament of the penis without removal of the corpora cavernosa more proximally. It is indicated for the penile tumors whose size or location would not allow excision with an adequate surgical margin or preservation of a remnant sufficient for upright body. The figure of total penectomy. Treatment of renal lymph node. Inguinal anatomy. Inguinal lymph node are divided into superficial and deep groups separated by the fascial art of thigh. Superficial group composed of 4 to 25 lymph node. It is comprising the 5 anatomy group. Central nodes around the SFJ, superior lateral nodes around the superior circumflex vein, inferior lateral nodes around the lateral femoral cutaneous vein, superior medial nodes around the superior external pudendal vein, and inferior medial nodes around the great saphenous vein. D group. D group lie medial to femoral vein in femoral canal. Nodes of Cloquet is most cephalate of the group. External iliac lymph node receive drainage from the deep inguinal, obturator, and hypogastric group and drain to common iliac and para-aortic nodes. Nice. Physical examination of lymphatics. Carcinoma in situ and verrucous carcinoma. Is lymph node examination is positive. If lymph node is positive, if lymph node is negative in carcinoma in situ and verrucous carcinoma, go for observation. And if it is positive, go for 4 weeks of antibiotics. If adenopathy persists, then go for FNAC. If it is negative, then go for excisional biopsy, and it is negative, then for observe. If adenopathy persists and go for FNAC and go for in result is positive, then go for ipsilateral inguinal superficial or deep and pelvic node dissection and contralateral superficial inguinal lymph node dissection with frozen section analysis. T1A comprises tumor involved the subepithelial connective tissue without lymphobascular invasion, is not a poorly differentiated. It is grade 1, grade 2 tumor. If it is physical examination is negative, then observe. If it is positive, go for FNAC, and if FNAC is positive, go for positive, follow positive algorithm. And if FNAC is negative, go for excisional biopsy and follow algorithm. T1B and T1B to T4 stages. Physical examination of lymphatics. If it is bilateral negative, go for bilateral superficial inguinal dissection. If it is negative, then observation. If it is go for dissection if frozen section is positive, go for ipsilateral inguinal, deep superficial and deep inguinal lymph node dissection. In unilateral positive mobile less than 4 cm, go for ipsilateral inguinal superficial and deep and pelvic lymph node dissection with contralateral superficial inguinal dissection. If it is contralateral positive, then go for contralateral deep inguinal and pelvic lymph node dissection. If it is negative, then observe. Bilateral positive mobile lymph node less than 4 cm considers for FNAC. If FNAC is positive, then bilateral inguinal lymph node dissection, and go for neoadjuvant chemotherapy followed by ilioinguinal dissection, and lastly followed by adjuvant therapy.
One thing that I still not able to understand even after 2.5 decades. If the bilateral are positive and they are not this is going on. Your voice is not being heard. Go ahead with the discussion.
Lastly, for fixed nodal metastasis more than 4 cm mobile nodes and pelvic nodal metastasis, go for induction therapy. If it is responsive or stable disease, go for ipsilateral superficial deep dissection and pelvic dissection and contralateral superficial dissection. If it is progressive of disease, then go for clinical trials, palliative chemotherapy, chemoradiation to the affected side. If it is further progressive, go for hospice referral. Radical ilioinguinal lymphadenectomy indication is resectable metastasis adenopathy, may be curative when the disease is limited to the inguinal nodes, as a palliative procedure in patients with documented inguinal metastasis who are fit for surgery. Pelvic lymphadenopathy should include the distal common iliac, external iliac, and the obturator nodes. No further benefit is gained from the proximal iliac or para-aortic dissection. Modified inguinal lymphadenectomy. Key aspects of the procedure are shorter skin incision, limitation of the dissection by excluding the area lateral to the femoral artery, preservation of the saphenous vein, and elimination of the need to transpose the sartorius muscle. Primary use of modified inguinal lymphadenectomy currently is in patients with primary tumor that place them at increased risk for inguinal metastasis and clinically negative groins on examination, stage 2 or greater, presence of vascular lymphatic invasion or high-grade tumor. If nodal metastasis is detection of frozen section, examination of a specimen, the procedure is converted to a standard extended lymphadenectomy. The false negative rate for this procedure in terms of detecting inguinal metastasis disease range for 0 to 5.5%. The limits of standard and modified groin dissection. The follow-up for patient with no evidence of inguinal adenopathy who do not undergo initial lymphadenectomy. The follow-up provide guideline for the more intensive follow-up of high-risk patient, especially within first 2 years. It is imperative for the patient and physician to adhere to such follow-up agreements and to be willing to intensify immediately if initial inguinal parameters are changed. Chemotherapy. It is indicated in advanced penile cancer presenting as a either bulky or unresectable regional disease, visceral metastasis and initial presentation, or disease recurrence. Like a cisplatin 5-fluorouracil, cisplatin adjuvant followed radical lymphadenectomy, 82% of 5% survival. Neoadjuvant fixed inguinal nodes, 56% resectable or 31% cured. Advanced disease, 32% response rate and 12% treatment-related deaths. Radiotherapy, primary tumor, external beam therapy response rate 56%, failure rate is 40%. Brachytherapy response rate is 70% and failure rate 16%. In tumor size less than 4%, radiotherapy is given. Complication is telangiectasia. Most common complication is telangiectasia. More than 90% of patient. Metal stenosis is approximate 30% of patient. Irreversible strictures, fistula 35%. Penile necrosis, pain and edema. Prophylaxis not recommended. Phase 2 prevent meds, morbidity and difficult to follow. New adjuvant can render the fixed nodes operable. Adjuvant therapy given may be used to reduce local recurrence. Radiation to inguinal area is not as effective as surgery for the treatment of the inguinal nodes. Non-squamous penile malignant neoplasm, basal cell carcinoma is rare, high-risk variant with low metastatic